In terms of systemic chemotherapy options for patients with metastatic disease, the approach is such that you're improving their quality of life and survival and treating them as a chronic patient. So it's unlikely to cure them, but the idea is to keep them well, symptom-free, and minimize the ill effects of the therapy to allow patients live a longer and better life. And so the general approach is that chemotherapy should really minimize we should minimize the toxicity of chemotherapy, but also get the most response out of the agents that we have. So 5-FU, fluoropyrimidine, so either infusional 5-FU or capecitabine, are the backbone of this approach, similar to other GI tumors. And we know that addition of platinum therapy, so a 2-drug combination, has been shown to improve quality of life, survival, efficacy, response, and so on. So the 2-drug combination with 5-FU and oxaliplatin is really the backbone for most of these clinical trials and for standard therapy. Historically, third drugs such as anthracyclines, epirubicin, or taxane, there's some data to support their use in combination to improve response. The toxicity from these agents is quite severe, and there's been several studies, modern studies, demonstrating that epirubicin really does not add anything in terms of efficacy to the 5-FU platinum. There was several studies to show that FOLFOX or even FOLFIRI, which is 5-FU irinotecan, are equivalent in efficacy, survival, and much less toxic. And epirubicin can actually result in toxic-related deaths. We do occasionally consider addition of a taxane to the backbone of 5-FU in platinum, and this is in select patients, and the treatment is generally considered only in young patients with large volume symptomatic disease, and in patients in which there is no biologic first therapy that we could add to 5-FU platinum. And so in those patients, a 3-drug combination could be considered. And there was even recently a consensus statement published in JCO with leaders in the field. This was in collaboration with MSK, Dana-Farber, University of Chicago, and really led by Jafar Jani's group at MD Anderson, saying that epirubicin should no longer be considered or ever used as first-line therapy in metastatic treatment for gastric or G-junction tumors.
So the primary goals of therapy for metastatic or locally advanced unresectable disease of both of these tumors is palliation. So palliation is obviously of critical importance in these patients who are metastatic. We know that they're not going to be curable, the large majority of them, and so the goal of therapy is palliative.
The issue with gastric cancer, G-junction cancer, isn't a lack of effectiveness of the chemotherapy, it's whether it's durably effective. And there have been a number of studies that have compared a variety of combinations. I actually favor FOLFOX, which is 5-FU leucovorin and oxaliplatin. That maybe is a triplet or a doublet, depending on how you consider the leucovorin. We use that pretty much as a backbone for our treatments if we're combining it with other biologics, let's say, or as monotherapy. Now, if you look at the studies have looked at combinations like ECX and EOX, that's epirubicin, cisplatin, and capecitabine, or with oxaliplatin instead of the cisplatin. And more recently, at a combination called FLOT, 5-FU leucovorin, oxaliplatin, and docetaxel. All of those have been used, and in fact, the FLOT regimen appears to be a little bit better than the others in the neoadjuvant treatment of gastric cancer prior to surgery. But for advanced disease, I favor FOLFOX. It's well tolerated. Patients with gastric cancer, with certainly advanced gastric cancer, are often malnourished and not in good shape, and I think FOLFOX is the best tolerated of all of those treatments. In terms of, in general, we use combination treatments. Even whether if it's HER2 positive disease, we might use it with a platinum and a fluoropyrimidine. If it's HER2 negative, we would do something like FOLFOX or ECX or FLOT, perhaps. All of these are multi-drug combinations. Again, the challenge is not so much to get a response, but to see if you can make it last.